Mo, oh my gosh. Happy New Year.
Ha- well, happy, yes. I'm happy it's not 2020 anymore.
Right?
And the doctor is in, and we got a lot to talk about
We
tonight.
have a lot to talk about today. What a
Yeah,
day. What a day.
yeah,
And it's not
yeah.
even over yet.
I
I'm right
have a
in it here
feeling.
in Maryland,
Mhm.
but I'm right at, it's like 30 minutes from me where that all that mess is
That's
happening.
right.
I have a feeling it's going to be a long night in America tonight. And you know what? Maybe it should be, because people keep saying
Mhm.
this is not who we are. This is not who we are. No, this is exactly who we are. And I think the sooner we reconcile that and come to terms with how we look, not just to the rest of the world, not just to one half the country, but to all of the country. As soon as we reconcile how we look in the mirror, the better our chances are to tackle things like healthcare disparities, especially as it relates to things like cancer. And that's what we're talking about tonight. We got to talk about disparities and evolving this conversation and pushing it forward and moving beyond symbolism to substance. Right? What is the substance of the matter of this, and how do we
What is the
begin to
essence?
develop actionable goals?
What is the essence of this? What is the root of this? And it
Yeah,
is deeply rooted. And when we start thinking about health disparities, it all starts with what's going on, right?
it's true.
Well, we got to celebrate the good news first, okay? And we have a Georgian in the house too, so we'll talk about that. But
Hey,
but guess what?
Hey.
A Jew and a black person are changing the game.
listen, the HBCUs are coming through. I see some D9 representing. I'm excited about life
Right.
and about the opportunities for
Yeah.
change in this country, because every challenge presents an opportunity, and nobody knows that better than cancer patients, cancer survivors, meta thrivers, you name it. Those who have faced a diagnosis of breast cancer know better than anybody that sometimes you got to turn stuff into fertilizer and let some important and necessary things grow. So we go talk to some farmers in the house tonight. We got
Yeah.
some people who know some things about growing from fertilizer. So
Right.
Ricky, would you like to introduce our guests or allow them to introduce
Let's
themselves?
let them introduce themselves. And it's so funny. We're calling this the Tia and Tamara show.
Sister,
So
sister in the house.
I know the sisters are Tamara, you go first. Babe.
Sure. First of all, it's such an honor and privilege to be here. My name is Tamara LeBan Jones, and I'm the founder of Diverse Health Hub. Sorry for that. An organization that is focused on really connecting with patients, providers, related to health equity, providing resources for these groups. So that's really what we focus on, and the communities that we really look to are BIPOC communities, Black, Indigenous, people of color. And so we have been around for about a year now, and we're growing, and I look forward to sharing more. But um, it's 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 um, it's my life's work. That's how I'll describe it. So
And your
I'm
time is
grateful
now.
to be here.
And your time is now. What a better time than this, right? Right. And my
I
Tia,
could, you
my Georgia girl. I'm sorry.
no, go ahead, go ahead.
My Georgia girl, my Georgia peach.
Yes, hello everyone. My name is Tia Tomlin, and I want to thank Dr. Mo and Ricky for having me. I am the co-founder of My Style Matters. We're a nonprofit organization based out of Atlanta, Georgia, that provides support to cancer patients. We do advocacy work on the Hill, both at Capitol Hill as well as the state. We also support, we have a sisterhood called My Breast Years Ahead, where we support close to 550 women who have all been diagnosed with breast cancer. Provide financial resources, education, not only to cancer patients, but those that have never been diagnosed, because prevention is important and it is key. And we also support caregivers as well. So I'm excited to be here tonight to talk about this topic of health disparities and keeping it to the forefront. So thank you.
We are excited to have you both. I think if we started to begin to outline the scope of the problem, we could possibly be here for the entire hour just outlining the problem. But some of the highlights that we could talk about certainly include the differences, the parity, if you will, the disparity between the mortality of Blacks and non-Blacks with respect to breast cancer, with respect to the diagnosis, the late stage. We're more likely to be metastatic, you name it, hypertension, diabetes, COVID, the coronavirus has wreaked havoc on our communities. We are more likely to contract that virus. We are less likely to be hospitalized as a result of it, more likely to die from it. And so we know that healthcare disparities in this country, that there is inequity, and it is really deeply rooted. And I guess, Tamara, we're going to let you talk first and tell us a little bit about how your work came to be, and maybe some of the history of what drove you to that work, and how it relates to our topic tonight.
Absolutely. Well, for a long time now, myself and the team that I work with, we've known that, health disparities and racism are inextricably linked. And it would be foolish to think otherwise. And so I often think that, sometimes people think, you know, people being in the back of a police car, that's kind of where the tragedies happen. But sometimes it can happen right in the doctor's office, and there's a lot of physicians I respect, obviously, but it does happen. So, what led me to this work is for the last 15 years, I've been producing content for cancer patients, but I realized um, perhaps it was that I wanted to really serve communities that sometimes didn't have anywhere to turn. And so that's what we kind of said, okay, let's take a minute. Let's take a step back here. There are communities that are getting exactly what they need. They're equipped, they have everything. And then there's others that, they have nothing to turn to. So for me, when I went to I went to an appointment several years ago, and my doctor said, hey, you have fibrocystic breasts. I want you to get a closer look. I'm going to recommend that you go to this medical center. And, she put in a referral. I showed up, sat in the lobby for about 15, 20 minutes. I was 26. And someone came over to me and said, we don't see patients that are your age. And I'm sorry, but I'm going to cancel the appointment, and I'll chat with your primary care doctor. Well, I didn't know what to do. It's like,
Wow.
okay, well, I'm going to go home then. But I think what really got to me is a few weeks later, I got a bill for several $1,000s. And it was like, whoa, how do I explain this? And so while I had the resources to fight for myself, I knew where to turn. It just made me think, how about others in this situation, who they don't know how to fight that bill, and they don't want to ruin their credit. They don't know who to turn to. So that's kind of what has coalesced into this vision for DHH, really kind of serving communities that have nowhere to turn. And so that's a great deal of what we do. We meet communities where they are with the resources, and we also listen. So that's extremely important. So in my past, that wasn't happening quite a bit when I was serving cancer patients in the past. And so I wanted to make that part of the picture. And so Diverse Health Hub was born, and it really is, I volunteered, or I should say, this was a self-funded effort, for several months. And so now here we are. So, so yeah, that's a little bit of the story and the journey in terms of how DHH came to be. So
But go back for a second. Go back. So you went to the doctor. You had an issue. You went to the doctor. You made an appointment, and they told you to go home. So did you ever get seen? And then they gave you a bill.
never got
You never
seen.
got seen.
Yeah, they said we don't see patients. We only do mammographies on patients that are 40 and above. And so I said, well, my doctor said that I had fibrocystic breast. And so she felt some things and she wasn't sure. So she just wanted to have a closer look. Well, we'll talk with her in that office and take care of it. And I did feel it was weird. It was strange, certainly. But I think the bill is really what kind of, it was like, what, it was very difficult. But again, I knew how to get out of that. I don't think everyone knows or has the resources to say, wait a second, this is nothing. Some people stress and worry, and there's a whole set of other issues. I didn't have to go through that, but again, and unfortunately, my story ended this way, right? There was nothing wrong. I have had some mammography since then, since that appointment, but it could have been a different story, you know, if something was actually wrong.
What if you
And
had
do you
cancer?
think,
Yeah. what if you
let me
had-
ask you this, because I hear a couple different issues, but do you think it was more or as related to your age or your race or both? And the assumptions of your level of health literacy?
You know, I think it was the first. I think it was my age. That's the first thing they mentioned to me. We don't see patients your age. I mean, typically we don't. And it was more of an apology, but leave. Like, we have other things to do, you know? So,
I can't tell you the number of young women with breast cancer that this is their first encounter with the health system. And you know, when you get your job, you get your health insurance, and you don't know how to use it. You really don't know how to access all of the benefits of it. And so you learn as you go. And so you go to see the
Right.
doctors that the doctors told you to see, go get the imaging that they thought you should have, only to be turned away. And in some instances, that being turned away is fatal, you know, and
right,
it really and women are turned away for many reasons, you know, notwithstanding their age, but also at times they can be disbelieved because of their race, and we've seen some really clear examples of that,
Oh, yeah.
even just, you know, ripped from the headlines in the last month and a half, when we look at the mortality of coronavirus and the disproportionate treatment of Black and Brown patients within the health systems themselves. So it sounds like you have
right.
really important work, you know. Do you ever feel like you're just patching up a dam?
I do. You know, because I think oftentimes people, you know, when they think of health disparities, it's like, oh, you know, let's throw a few dollars and move on. But it's so deeply rooted, it has such deep roots until it's almost like, you know, we took such a long time to get here. It's probably going to take just about the same time to kind of clean this mess up. And so people don't often think of that. We can't just say 2020 was the year, we're done, we're good. It doesn't really work like that.
See, let me pull you into this conversation because you've been doing a lot in the DEI space as it relates, especially to cancer. But tell us a little bit about some of your work and some of the challenges I think that you've been facing.
Yeah, I mean, I would definitely agree with Tamara. You know, when for us, our organization got started simply because when I was seeking out help, looking for people that look like me through support groups, no one looked like me. And I really couldn't talk about my journey because at the time my company was going through a layoff. So, you know, I didn't want to put myself in a position where I lost my job. And so I was very quiet about it. But like I said, I went to support groups and no one looked like me. And I said, this is a problem. I know we exist, but where are we? And when I was going through treatment, I'm a breast cancer survivor, for those who don't know. When I was actually going through treatment, there were so many questions that I had that were unanswered. And there was a lot of challenges that I was experiencing that as I talked to other women who looked like me, they were experiencing those same challenges. Communication, you know, things were not being shared with us about just how to navigate this journey with doing things that's within our control, right? So things weren't being shared with us. Our treatment plans were a little different, although all of us were being diagnosed with triple negative breast cancer, same stage, same scenario, but it was a little different. And so we had different doctors that we saw. And I was like, something's wrong with this. You know, we've got to change this. Is it because we're young? Is it because we're Black? Like, what is the issue here? And why is that different? And the more and more, you know, I knew when I got diagnosed that I needed to be a part of change. Like, I knew this was not just about me, this was bigger than me. And so as I got more and more into it and start having just more and more discussions with others, and you start to learn more and you start to see trends and you're like, wait a minute.
Right.
Now you start to question, really, was it a thing with me being Black, or was it a thing of, you know, being young? What was the real issue? And so having our nonprofit organization kind of helps to bring those things together. And like I said, even with the sisterhood that we support, we're able to see those trends. We're able to have those discussions amongst from one survivor to the next, and really look at, with the doctors that we all have, is this happening with just the Black women, or is it happening with both Black and white women? So it helps to open that up and helps us to have more of a dialogue about those things.
Well, the data says that Black women under 35 get breast cancer at twice the rate and die at 3 times the rate of white women. So it is a young Black women's thing, but I mean, it's a different disease for young Black women. And so there's something going on with that needs to be addressed. Frankly,
And it's compounded. Mhm.
yeah. And the mammogram guideline of 40 does not work for us.
I was just gonna say it. That therein lies the challenge.
Right. And so you go present, both of you present with issues, and we're dismissed, which we see so much. But you're right. I mean, something is not right.
Yeah.
And
I mean, it's interesting. You talked about, just working with other women or thinking about other women who may not know how to address some of the issues around, their bills or what have you. I remember going to treatment with a woman, and she didn't have any family or what have you. And she was just really going through some major things in life. And when I went to her doctor's appointment, I started to ask a lot of questions because she didn't ask any questions. And the doctor stopped and looked at me and said, "Well, are you a doctor? Like, how do you know all this information?" I think he was very offended that I was asking a lot of questions.
Wow.
But I was there to support her. And I didn't think none of that mattered. Like whether I was a doctor, whether I was in healthcare, none of that mattered. Just answer the question so that she can get the help and support that she needs. And by me showing up, also said to him that you can't just do anything to this woman because she does have support. And we have a lot of those situations where women don't have the support and they really need it. None of us have ever gone through cancer. We don't know anything about this. And so being there to be able to hold their hand and try to address those issues and being able to see when it's a bias that's happening to a particular patient is so important.
Absolutely.
So Tamara, let me ask you this, because the conversation is about how do we evolve this conversation, and I guess to your organization and your organization's goals, have you encountered challenges in your advocacy work? And Ricky, I guess this question is for you, and Tia, for you also, because you all participate in advocacy work, even at the legislative levels, I think. But tell me about some of the challenges that you've been facing most recently.
Yeah, absolutely. I mean, I think it's a good question because I'm sure Tia can relate. She's facing challenges, or they're brought to her. But I think, one thing we've noticed is people, I will say this, there's a condition that we cover called renal medullary carcinoma, not breast cancer. It's attached to sickle cell disease. But, and typically people with a sickle cell disease or sickle cell trait, sometimes they can get this cancer called renal medullary carcinoma. It's rare, but when this cancer is fatal, like it's extremely aggressive and typically impacts young adults. So what I've been trying to do over the last year, working with researchers and advocacy groups, to really bring this to the forefront, because young people are dying senselessly. Industry, I go to, as part of the work that I do, I work with industry to get sponsorship for doing educational programs. Well, there is zero funding, apparently. This is not a priority. And unfortunately, and I'm bringing this up now because if now young people today, they feel like if they get that diagnosis, it's a death sentence. And it's really because there are not enough of them dying. We haven't gotten there yet for anyone to pay attention. And it really saddens me. It breaks my heart. It really does. But those are some of the challenges that we've run into because they come to us for help. And it's kind of like we feel like we can't do anything, almost. And so what we have done is just put our own dollars into this to try to bolster, amplify like awareness around it. But, I think that's some of the challenges that we run into. It seems like, if industry is not, if it's not a priority, then there's really no funding or dollars that will go into those buckets for those patients. So we've taken it up on ourselves to try to make a difference. It's an uphill battle, but that's definitely one of the challenges. It's very difficult. And it's almost like we have to reach a quota in order for someone to say, okay, 5,000 deaths, let's go ahead and see what we can do about this.
It's kind of like triple negative was 10 years ago, you guys. If you think about it,
Tell us more.
when I was sick, I wondered, why isn't there a drug for triple negative? Why isn't there a therapy? Why don't we have a preventative drug? Is it because we're dying too quickly? Is it because, our mortality rate's higher? Is it because we're Black women? Like is it Jewish women? Like what is it about our disease? And thank God, for the past 5 years, we've gotten attention. Now we've got some therapies, and plus we've got a lot of stuff going on, a lot of research. But I don't know why. Like, I don't know at what point. You're right. There's like a tipping point of how many people have to die or whatever or suffer to be able to get attention. But I always go back to my AIDS analogy. 20 years ago, the AIDS community was small, but they came together in unity and went to pharma, went to Congress and said, we're having sex and dying, fix it. And they did. So to me, that's why advocacy is so important, because it's a way to get attention, so like be the squeaky wheel. And I don't really know what came over the triple negative arena that made people go after it. But, thank God for the work that's being done. But you wonder what makes people, I hate to say at the end of the day, money drives all these decisions. I don't know.
Let me play devil's advocate there, Ricky, and ask you about this. Because I feel like even in the HIV/AIDS arena, right, there still is a disparity. And it still disproportionately affects the quality of life and the mortality of Black and brown people, now Black and brown women, even more than men, right? So HIV/AIDS is still problematic for our community. So you have this sort of trickle down effect, right? And I see the same thing, and I guess I'm asking for some validation in that. When breast cancer survivors and advocates go to the Hill, right? We have these days on the Hill, and we go, there are the squeaky wheels, there's the Colemans, there's the, ACSs, and then everything else is supposed to just kind of trickle down to the rest of the organizations and the rest of the agenda. I guess the question is there disparity even in advocacy and what you've seen and in your lived experience for you and for Tia?
Oh yeah. I mean, do you want to take this one? But there's still racism even within our breast cancer ecosystem. I mean, it's across the board, Mo. That's why this is such a big topic, our big issue, because there's so many layers. And I think you said that earlier, Tamara, that there's so many layers to peel back and on this onion that we haven't even uncovered all the issues. But it's really deeply rooted across so many areas. I think that's what you saw today in the streets, that there's some like underlying just racism, in our world that we don't know what all those people do. They're going to go to work tomorrow or in a couple days and go back to their job and their lives and do some bad stuff that, that's going to reflect exactly what they did in the street today. Right. So all of that sort of underlying, bad stuff is all around us, but we have to figure out, how do we overcome it? And I do think we're in a really good position right now. I'm always a hopeful one that because, the one thing COVID did do was put all this on the table, and people are concerned. I talked to 3 different pharmaceutical companies today who are saying, what do we do? How can we help? How can we change it? And so I think there's a desire, but people just don't even know where to start. Where do we start? How do we
Tia, where do we start?
Yeah, so one of the things that I think that we also have to be mindful of, and I guess I'm going to play devil's advocate here. Last year there was so many. Say it again.
I'm getting funky feedback. Can you guys hear it?
Yeah,
Yes, I can
kind
hear
of
it
like
too.
Max Hedrick.
I do? Oh, wow.
Yeah.
Oh,
Okay,
it's
is
better
this
now.
better?
Yes,
Mhm.
you're good.
Okay. I don't know what
better.
happened.
Yep. That's
But what I was going to say is, in looking at the flip side of this, last year it was like popular to be Black, right? There were so many solidarity statements that were written or what have you. But one thing we just need to be mindful of is, when it comes to health disparities or when it comes to trying to address this issue, looking at what all took place last year, I am very appreciative of it, but we can't stop the fight. We can't stop advocating. We can't stop pushing. And what happens is, even though the flames have kind of died down and now there's another hot topic, that everybody's talking about in the world today, we have to keep pushing. We have to now hold these companies, these organizations accountable. We can't just do all this pretty stuff and, do pledges and do, solidarity statements and all of this stuff and, have all these talks with, we're now including Black people on our talks. Well, it's got to be more than that. There's got to be some action, and we've got to hold them accountable. It cannot be, yeah, we've included you, but it's really the illusion of inclusion and not really truly inclusion. What does that look like? When we talk about, health disparities, are we highlighting that the health disparity is for people of color, or are we really focusing in on Black people? And not to say health disparities don't affect other ethnicity groups. I mean, you can say health disparities, and that could be, we're talking about people who are at a disadvantage. It could be women, it could be LGBT, it could LGBTQ, it could be, it could be so many different things. But if we really want to address the problem when it comes to Black women and Black breast cancer, we have to really call it out, and we have to come together as organizations and really unite. We have got to unite, and we've got to find ways to hold these organizations accountable. Okay, you signed off on something, you did this, you did a solidarity statement. What have you done differently within a year?
And so
aside from inviting someone to be on your panel that's Black, it's got to be more than that.
Right. Your
that's
free
not enough.
advisory position. Sure. Mm-hmm.
Yeah. And
So,
we've made,
agree with Tia.
I think we've made progress. I mean, just looking at what happened with the votes, right? I think with everything that has happened over the past year, it has pushed people to the polls to vote. And now people see that they have power to bring forth change, but we can't stop there. It has to continue.
Right.
Exactly. So I really believe those are ways for us to keep it in the forefront. We have to keep talking about it, but we also have to, hold some accountability.
Mm-hmm.
And work together. We have to
together. Yeah.
How I feel about that whole alliance thing, that not one of us can do it alone, that we have to join forces and work together and help each other and support the cause. But I think that I think we have to be specific about telling people what to do for us. You know what I mean? So what I've seen in the last years, there's been a lot of, okay, let's hire a diversity and inclusion VP. Let's create a diversity and inclusion department. But what does that mean? Does that mean hiring? Does that mean you're going to hire more Black people? Does that mean you're going to recruit more Black doctors? Does that mean you're going to find a cure for a Black disease? What does that really mean? So I think we have to really be specific and challenge our partners in our ecosystem to say, all right, well, what are you actually going to do? So are you going to do something at HBCUs? Are you going to do, and I think we just have to sort of be in our own minds, think about some of the things that we know are going to change the tide, right? Like we knew that voting would, so we voted. So what can we do in our health arena to say, does that mean, putting a mammogram machine, whatever, mobile units, whatever, in the right neighborhoods? Does that mean, building a Black clinical trial facility in DC? That's my dream, is to, build Black clinical trial facilities in major cities. But we need to put our money where our mouth is.
Right.
And make the right investments and show that there's some, tangible things we can take away from this. And, they keep talking about Black people aren't going to get the vaccine. Well, what are you really doing about it except for talking about it? Have you done something? I mean, and it's funny because I actually moderated a focus group the day that the Black doctor gave the Black nurse that vaccine in New York, And so I was talking to a group of Black women that night about breast cancer. And I said, what did you think about that? They said, oh, that was a prop. That was totally orchestrated. was totally jaded, like didn't do anything for me, didn't help me understand, because that was probably orchestrated by the drug company. And, they probably, they were right. I mean, but that was their attempt to do some marketing around the vaccine. But so what is it that you need to know about this vaccine? And actually, that's our next week's show. Especially get the vaccine. So what do people really need to know about that? And then do something about that. So it's like taking, there's so many layers and so many things, but are there some chunks we can tackle? So
action items.
to me, yeah, one of the biggest issues I think we're going to be dealing with in a year is screening. People aren't getting screened right now. And we already have a problem with that in our community, but right now because of COVID. So is there something that we could be doing right now to get Black women to get screened? And I'm, like, who can do that? Who has the power to do that, the money to do that? Here we are.
If you had a suggestion, what would it be?
Oh, I already started writing an article about it. I need a quote from you. So
No problem. I got no shortage of thoughts on all of this because
I'm going to put it out. Yeah.
It's so much larger than even we have time to discuss, right? So we're able to look at our unique circumstances. We can take, our one cancer that we certainly focus on, and we can talk about, the industry partners and what needs to be done. But when you refer to the ecosystem, the ecosystem refers to so much more beyond just the cancer centers and the screening and the insurance, issues and the patients. It has to go, back to the medical education, back to, the pipeline of even getting young students into medicine. And it's it's such a multifactorial problem. My favorite quote by Audre Lorde is that, there's no single issue struggle because we don't live single issue lives, right? It's all so interconnected. And so as we talk about how to push this forward, Tia, I heard you say that we need to, I think we need to organize a bit more and develop some measures of accountability. Like, what do the measures of accountability truly look like? And I guess that's my question for everybody. And even people who are watching, you want to participate in the chat. If you are going to talk about something that is measurable to show that we're making advances in, let's say, Black breast cancer specifically, what would those measures even look like?
Yeah. And I think, one of the ways or one of the starting points is, when we talk about there's bias in healthcare and with doctors or what have you. Well, every time I go to a doctor, I get an email with a survey. Well, I fill out those surveys, but my question is, what's the follow-up? What are you doing with those surveys? How is that, if that doctor is still there, and multiple people may have had issues with that particular doctor. So what are you doing about it? How are you addressing the issue? So that's when patients have to band together and start having these conversations internally with the hospitals, whoever is, in control of these surveys or what have you, and start asking the questions. Okay, you're asking for this information, but what are you doing with that? Because there needs to be a report back. And that's how you start to hold them accountable. Don't just, you're asking me for something, but what are you doing with that information that I'm giving you? And so there's got to be the accountability. And I think that's one place to start. And I think if we start to see change and we start to push back a little bit, that hopefully, we can push, if we're starting to see a lot of bias, for example, at a particular hospital, then we can start to demand, well, these doctors get, some kind of cultural training. And then there need to be some kind of point system or reward, how they're compensated based on performance. At my job, I get compensated based on performance. So it's the same situation. How are we addressing this?
Exactly. I couldn't agree with you more, Tia. The cultural competency portion of it for healthcare professionals, oftentimes, some patients or people get intimidated. You see all those letters at the end of their name, and, at the end of the day, they're human. And so I think cultural competence has a place and should be pushed a little bit more, even mandatory, in my opinion. And, just related to COVID, I think for, all the ladies here, you might agree with this. I don't think COVID told us anything that we didn't already know.
Oh yeah. years.
Yeah, related to disparities, it was just
Told
kind
the
of
rest
like,
of the world.
yes,
Oh,
it
yeah.
told the rest of the world, but we kind of, we were onto that. You know, and again, I know I bring up the past. I'm the one on the panel who goes way back, you know, but this ladders back to slavery. I hate to say that, but you know, the diets, generations that ate various scraps of food. I mean, there was an actual bin, there was a name for it, where the slaves would eat out of, you know, that there's a reason why a lot of Black people like oxtails. It was not something that was desired. It was thrown out. So there's a lot of that over generations of just bad nutrition. And you know, you know, autoimmune conditions, compromised immunity, and so impacting some of those communities. And so I feel like the movement, you know, last year was a moment that turned into a movement. We need to continue that movement, obviously, and it requires years of leadership, top down, bottom up, commitment to really to see this through. And I think the most important thing that we try to get out there at DHH is when you neglect vulnerable populations, it actually hurts everybody, everybody. So, and it's pretty costly too, really costly. So
About that.
that's a whole nother conversation.
Right.
But it's, yeah, I'll just leave that there.
And even down to like health literacy, you know, how are we empowering communities? If we want to see these things change, then how are we educating them when it comes to their health? You know, I mean, I think about COVID, and, you know, I just went through this, you know, with COVID, and a friend of mine, and it's like, you know, I don't want to go to the doctor because of the bills. Don't worry about the bills. You know, I could either be planning your funeral, or I could be, you know, paying bills for your health care. And there are programs, but when people don't know about programs that can assist them, they pull back. And so I think even down when we're looking at how can we address some of this, again, health literacy is one component. How are we educating people to take control of their own health? If we want to eliminate people from going to the ER, we've got to educate them.
I love that. And let me ask you the follow-up question to that then is, well, what did you know and what were you taught about breast cancer before you got breast cancer? And, you know, what did your education look like and what do you think it looks like for the average person?
Right.
Yeah. The only thing that I knew was what I learned in the 7th grade. And I learned how to do a self-breast exam.
Wow, that's
Not
pretty
that it
impressive.
was, you know, not that it was perfect, right? But
But that's pretty
what made
impressive.
me
to set
tune
the
in, yeah, what made me tune into my PE teacher was I had an aunt that was diagnosed with breast cancer. And the only thing that we talked about in our home was Aunt Linda had breast cancer. She lost her breast and don't talk about it. And that was it. So I knew that I didn't want to get breast cancer. So I better touch my breast. I better get to know them. I better feel them. I really didn't know what I was doing at such a young age. So it wasn't until I saw my gynecologist that I started asking about it, you know. Still didn't know a whole lot until I got diagnosed. I only thought that there was one type. It was just breast cancer. It wasn't even, you know, all of these subtypes. So again, that's something that's just so important. But beyond that, how many times have we gone to our doctor, not even, you know, from an oncology standpoint, a specialist, just your PCP, and they've said something to you that you don't understand? Or you've tried to read, you know, go into your portal and try to read something, you have no clue what it's saying. And your doctor just tells you, oh, you're fine, but you really need to read your own reports about you, because sometimes there are things in those reports that you need to be aware of that your doctor may not even pick up on. And especially if you are a person who's on Medicaid, that doctor is only spending about 10 minutes with you. So a lot of questions that you may have, or you may not even know what to ask, those things are not being resolved. And so this goes back to health literacy. How are we empowering people to take control of their own health?
Or what if you don't even go to the doctor because you don't have insurance, and you do like your friend said, you know, well, I can't afford it, so I'll just stay home.
Right, but that goes back to health literacy and educating them that there are clinics, free clinics that are available, just to get a baseline of your own health.
I can tell you,
most pharmaceutical companies actually will help you with drug costs. If you have a problem, you can apply for that, and get the drugs that you need, but people just don't know about it.
Yeah.
And they
There
don't
was
know
a-
how to do about it.
Yeah.
And it's up to the health systems to help people utilize it once you get to that point. But the thing that makes me sad is that, as I'm listening to you talk, I can't tell you the number of women who come to my clinic for non-surgical things, breast pain, fibrocystic, lots of different things that they don't necessarily need surgery for. Genetic counseling, right? We go over family history and talk about whether or not you should get hereditary cancer testing, all those things. And in the course of the conversation and exam, I'm constantly pointing things out to them. This is what this feels like. Here's what this feels. Here's what this should feel like. Did you know that there's a shelf of lumpy breast tissue underneath the bottom of your breast called the inframammary fold? I call it nature's underwire, and it always feels lumpy right there, and it feels the same on both sides. And we compare, and I'm like, now take your hand and you feel it. And they leave and they say, nobody ever told me what my normal breast was supposed to feel like.
Wow.
Right? How many of our doctors even just say, here's what normal? They go, nope, okay, you have dense breast, see you later.
Right.
Yeah. What I've heard is a few times, and I got upset about it. The doctor's like, when I went for my second mammography years later, oh, it's probably nothing. Are you sure you want to do this? And it was kind of like, huh? It's probably nothing. You took no test. There's no blood work. There's no scans, but it's probably nothing. And I've heard that before. And I think it's this, it ladders back. Somehow we are so strong and invincible. We don't feel pain. We don't, you're good. You look like, I don't know what it is, but I've gotten that a few times. And does anyone have any advice for patients who kind of encounter situations like that? If a doctor has nothing to rely on and they're just like, you're probably just fine.
I just talked to a friend of mine about that the other day, and his friend was feeling some pain and some lumps and this and that. And I said, okay, how old is she? And he said, she's 29. And I said, if she goes to her doctor and the doctor does nothing and says, you're probably okay, but we're not going to get any imaging or anything. I said, unless that doctor has x-ray vision, she needs to find another doctor.
Yeah.
There you
Right?
go.
It's interesting you bring that up because my brother, when he was 32 years old, he was diagnosed with stage 4 testicular cancer. And when he went to his doctor, immediately he and his wife went to the doctor, and the doctor just wrote him off like, oh, it's an STD immediately. And was like, here, I'm going to give you a script, take this medication. Of course, now husband and wife are in the doctor's office going back and forth, arguing with each other, like, are you cheating? Are you cheating? And it wasn't until they had that moment, where they just stopped and said, no, I don't believe that it's a STD, and his wife said, could it be cancer? She had no reason to say that, but something just made her ask. And the doctor was like, I don't believe it's cancer. No, I don't think it's cancer. And she was very persistent, and she pushed and she advocated for him. And of course he's, huffing and puffing like, this man just told me I have an STD, what's going on? And she said, I want him to see a specialist.
Stereotype.
But because he's, 32-year-old Black man, young, got tattoos, he's in here with his wife, you just wrote him off that he had an STD. And had his wife not pushed, my brother would have been dead had his wife not pushed. He was stage 4. 30 out of 32 lymph nodes, 29 were positive, and 1 was on the base of his aorta.
Oh my gosh. He's okay now.
Yeah, thank God. But it's those types of scenarios.
From testicular cancer, yeah, and a young single guy, and easily could have been written off as an STD. And I think we do that too often in our health community. We minimize people's their symptoms. We minimize what they're telling us. And certainly I think there's room for education for patients to help them to help us, because I could say, how long has this been going on? Classic example, oh, for a little while now. How long's a little while? Oh, since here and there. Okay, and we can go on for 10 minutes and nobody will say it's been 2 months, it's been 2 weeks, it's been a year, and so using our words and educating patients on how to explain things is something we can do as we talk about health literacy and prevention. I think there's room for that. But certainly when somebody comes with an issue, the first step is you got to believe the patient. And, you know, like we're talking about this example, it sticks with me because, you know, that doctor in Indiana was part of a group that I'm in on Facebook. And she was documenting what was happening to her as she was in the hospital getting an adequate treatment, and nothing that she could do, no degree she had could save her. And the CEO says, well, maybe she intimidated nursing staff because she was so, you know, well educated, that maybe, you know, her fund of knowledge intimidated the nursing. And we somehow now have blamed this patient for their untimely death that was attributed to a lot of other things besides her own education. You know, and it's just like, you can't start out not believing patients. You just can't.
And then on
That's
the
one-
flip side of that, on the flip side of that, look at the situations like me where my doctor told me I had 2 years to live because her own experience was she had only 2 triple negative patients and they both died in 9 months. I'm a Black woman, so I'm probably going to die. Like, what, you know, she had no right to tell me that. No, you know, well, here I am 9 years later, but like, what motivated her to do that
Yeah.
and kind of write me off? And I'm like, well, no, me and you we gotta go to talk to somebody else because we got to find an answer that works, because this is not working for me. But how many people walk away from that situation scared, feared, fearful, and don't do anything about it? So it can happen in every situation. And you know what? It almost boils down to, you guys, trusting your doctor or trusting whoever you're dealing with at the moment, right? Which is pretty scary when you're in that room and there's only you and the doctor. Like that conversation is so undocumented.
Yeah.
Anything could happen in that room.
I think the
Anything
most
could happen in
powerful
that room.
question that you can ask a physician in that moment, in any given moment, is, you know, whether you understand what's going on or not, they talked over your head, they got their hand on the doorknob, whatever it is to say, okay, if I were your mother, sister, daughter, spouse, partner, whatever, what would you do if I were your relative? And then you wait.
Mm.
And you
I
let
asked
them
that
talk.
question. Well, I don't know. I don't know. I
Every
can't answer.
visit.
Yeah.
At
You gotta get
DHH,
in front of the door and do that. Block the door and ask that question, you know.
oh, I just wanted to mention, just hearing all of this, there's one thing that we have been like really listening to, like I said, listening to the community and trying to figure out what resources are really gonna, create change. And one thing that was requested was kind of like this directory of providers. Who can I trust? You know, what is that's sometimes the fear from a lot of people. It's like, you know, is that doctor going to understand me? So we're building a directory where all these providers essentially have come together with us to sign these affirmations to commit to non-discrimination and, you know, despite race, treating patients with high quality of care despite their race, despite their age, despite, you know, all those some of those factors. And so it's growing. And so it's something we are giving back to the community, saying, hey, if you have this condition, these are a group of providers that a list that we've developed to help, you know, as a resource. And in one of the libraries, there's a doctor named Andrew Campbell, and he shared a story about one of his patients who almost died. She was requesting pain medicine, and a group of doctors, white doctors, you know, unfortunately, they basically sent her home and said, there's nothing more we can do for you. And she had a cardiac event, and Dr. Campbell saved her life. They weren't listening to her, and he knew she was telling the truth about the pain. And so, you know, she's alive today because of that. But it was literally 8 doctors telling her no, and this one doctor saying, hey, I know exactly what's going on here. And you know, she had sickle cell, not breast cancer. But again, it's happening in so many different areas, you know, so many people are impacted by these inequities. So really trying to drill to the bottom of that to empower people to be able to take that control and like, nope, I think I'm going to get a second opinion, maybe even a third, or just empowering people to know that the buck doesn't stop with one provider. And you're the most important part of this. You know the most about your body. You know, oftentimes, sometimes we don't even go with our gut. You know, we have these feelings. It's like, I and we just go the other way. But you know, just really making sure people are not afraid to act, and making sure everyone is has the resources to feel activated to do you know, to get the best care possible.
Yeah.
I
And
love
I
that
love
you
what,
said that because
oh,
you're right. Go ahead, Tia.
no, I was going to say, I love that you all are creating that directory, because I think that's important. And if it's driven by the patient, it's even more important because we trust other patients.
Yes.
You know, we trust other patients. And that's kind of going back to what I was saying, even within our group, how the women start having conversations about the different doctors and we get a chance to see if there are any trends. And I think
Exactly.
that's what everyone needs, you know, in their cities and
Yeah.
their communities is having some type of resource like that. So we know who to go to, you know, we know who we can really ask questions to, and we don't feel rushed. I remember one time going to see my doctor, and she had her hand on the door, was walking out the door in the middle of a conversation. And I had to stop her. And I was like, hey, I'm talking to you. And she turned around and looked at me, and she didn't say anything. She just stared at me. But I'm like, we're having a conversation. And do you not realize that you're actually going out of the room to go see another patient in the middle of our conversation? And are you programmed to do that because, you know, you're accustomed? I have a few minutes to spend with my patients because I have so many. And I understand that the doctors are overwhelmed as well, you know. So I think that, you know, to their defense, there needs to be a patient provider conversation. So we really understand the challenges that we both are facing so we can fix the problem together. We can't fix it separate. We have to fix it together.
Yeah.
Ooh,
Patients
I
and
love
experts
that
have
you
to be
said that.
partners.
Yeah.
Because
Yeah.
I feel like so much of how we begin to educate ourselves, right, as a community, then takes the complete focus off of the doctor, right, and off of modern medicine, and then we direct our focus to returning to the things that we thought we knew as far as holistic medicine and adopting natural practices and principles, and it almost shuns the experience of physicians, because it's like you can't do both. You can't walk and chew gum here anymore. It's like, you know what, we went to the doctor, they told me I need chemo on one chemo, so now I'm just completely banishing this entire system for another approach that doesn't include that doctor anymore. And that for me is a really tough spot to be in, because I encounter a lot of patients who, you know, once you get diagnosed with cancer, I get it. You don't want toxins in your body. You feel like you probably have enough toxins that might have caused this, that might have, you know, whatever the things are, but that partnership gets even more broken.
And it goes back to, you know, why did you go into medicine? Get back to that. Get back to when you said, I want to go to medical school. What was the reason why? You know, and I think if we help doctors kind of have that moment, I think if we work together, then we can affect change. Then we can start including the pharmaceutical companies and having these conversations. Then we can start talking to the healthcare you know, the health plans, and start having these conversations of where some of the pressures lie. And we can affect change, but we got to do it together. We got to have these conversations.
So what I hear you saying is, you coming to talk to my medical students at my next lecture on healthcare disparities. Can I count on you as a guest lecture? Can I count on all of you as panelists?
Right, all right.
You know, and you know, I don't want to always blame the doctor, because, you know, we have, you know, Dr. Mo, you know, I wish everybody was you, obviously, but because we have to teach our peers to stand up, that it's okay to challenge the doctor.
Yeah.
It's okay, because to your point, Tamara, we do know our bodies better than anybody else. And so when you walk in that and you have that 8 minutes or that 10 minutes, it's okay to say, no, I need more time, or this isn't right. And so we can't be intimidated in that situation and just assume that the doctor is focused and right. They may be having a bad day, whatever the issue is. So we have to know that we are in control of that conversation and not vulnerable, even though we are vulnerable because we're sick and we need a skill that we don't have. But we have to teach people that it's okay to say, hold on, wait a minute, I need help. And this just doesn't feel right to me.
Yeah.
You know,
and I think too,
education, you know.
Yeah, and there has to be a level of respect, you know, when it comes to having that discussion, and that a doctor doesn't feel like they're being challenged, that this is a person that's really trying to understand. I mean, I quote unquote hire you to do a service, right? And that service is to provide me with all of the information that I need to know about the disease that I've been diagnosed with. When it comes to making a decision, it's ultimately my decision because it's my life. But we can work together and you help me to make that decision, get to that point. But if I don't make a decision that you approve of or you feel as though it's the right decision, don't chastise me, don't write me off, don't send me a letter in the mail saying, oh, you're not doing what I recommended and I don't want to, see you as a patient anymore. It doesn't work that way. Doctors have been, they go to school, get their education to be able to be supportive. I think them to get the information and we work together to make a decision. But ultimately, the decision is in my hands. So I think that's another part of building the trust and building the relationships and us working together to be able to solve the problems that need to be solved. And I see that from time to time where, a patient may say, I don't want to do chemo. And the doctor just writes them off because they made a decision they don't want to do chemo. I don't think that's fair. And that's not right. But that's when you tell the patient, well, go see another doctor until you find that doctor that will be supportive of your decision.
Tia, I'm losing your sound a little bit, but I think the other thing is that doctors have to be transparent to help patients understand why they recommend certain things. And I'll give you an example of a patient who has disease that surgery will not cure, right? Surgery will not be curative, but they don't want chemo. So now where do we go? Do I do the surgery that's not going to really save your life because you won't do the thing that could potentially save your life? Understand all the reasons why, or maybe not even understanding the reasons why. And this is what I mean when we got to be transparent to say, okay, here are the guidelines. Here's why we recommend these things, and not just pulling it out of your hat because I want to run up your bill, or I make money or get some sort of kickback, whatever people think about what doctors get from prescribing these things, but because this is what we know that can potentially save your life. And I think if we had that conversation, actually studies show that there's 23% more uptake in more aggressive therapies among Black women when doctors have that really candid conversation and they take that time to explain why they recommend what they recommend. 23% more women will do the life-saving thing. Just don't talk.
And that's what I mean when I say lay all the information out on the table. Don't just give me the what, but give me the why, or give me the how, or all of it, And that's important. That transparency, I totally agree with you. That is so important. But even with all of that information, if the patient still makes that decision, because one of the things that I see is I do get people who have made those decisions. They want to go a holistic route. When I think about advocacy in the breast cancer space, I don't exclude them. That's their decision. They still have been diagnosed with cancer, and I still need to advocate for them in some kind of capacity. Don't exclude them, because that's, why would I do what I do if I exclude them?
Yeah, it kind of goes back to what you said earlier and kind of the golden rule. Do unto others as you want them to do unto you.
Yeah.
And so when you go to the doctor, maybe that's where you start. If I were your wife or if I were your sister, how would you treat me? Treat me that way. I think that maybe that's a good place to start the conversation with the doctor, that, like I want the one that pediatricians give their own kids, or, remember that Tylenol campaign, or what are you going to do for the woman in your life, the boobs that, check the breast that you love? What are you going to do about that? So maybe that's how a good place to start to get everybody on the same kind of playing field, and kind of challenge the doctor to care. I mean, at the end of the day, it's about how much do you really care? How much do you really care about your work, about what you do, and about your patients and about your doctors?
And about yourself, and about your life,
yourself.
and about your health, and all those
Yeah.
things as well. And so I'm hearing a lot of things. I know we're going to wrap up probably soon, but it sounds like the problem is so huge that
big.
there's different ways that we can evolve this conversation. Because getting back to our original point, right, of how do we evolve this conversation? Tamara, I think I heard you say a lot about the boots on the ground interaction with patients and making sure they feel empowered, right? And making sure that they have support, and that they have, as Tia said, health literacy, and that they have the advocacy and the person in the room who can raise these questions and who can be this voice. Tia, you also talked about medical education, right? And reminding doctors of why they went into what they went into, and maybe there's some room to do some, and you too, both of you, cultural competency, cultural sensitivity training that we
Yeah.
need to do. Ricky, I heard you say we need to tackle pharmacy and we need to
Yeah,
tackle
pharmacy.
industry.
Industry.
Yeah. And then
Yeah.
the coming together of all of it, right? Bringing all of that together.
Bring it all together.
Much
And,
more to do.
you know, we have all these meetings where, you know, we have the advocacy groups, and then we have the pharmaceutical people, and then we have the doctors have meetings, but who's having a meeting with everybody in the room? Where's the meeting where you have the patient, the doctor, the pharma person, you know, and what, you know, everybody in the room, and the advocacy person? Like, where are those convenings happening? And where's it? So, you know, at the advocacy meetings we may have a doctor present to us, but where's the conversation across the ecosystem where there's a level playing field in a room where we can all talk about the issues? So maybe that's a meeting we need to have, you know, with, have that, all the players in the room, everybody represented, to have these conversations. But we do have a lot of work to do, but I really do believe the time is now. So we got to figure it out fast, you guys.
Yes.
Because we just have to figure it out. And I think it just means every conversation that we have every day with anyone that can play a role here, we have to challenge them and say, what are you doing to bring action? What are you doing to bring action? What did you do to bring action today? You know?
Yeah, this work is not seasonal.
No.
I just want to say that because some people feel like, you know, it is. I want to make that point. It's something that we have to continue and, you know, embed it within everyday life to where we are tackling this head on. It can't just be for that 8 minutes and 46 seconds that we saw and we're compelled to act.
About it, not just
Or
during October.
Yeah, or COVID.
Precisely.
Right. It's everywhere. It's every day. And we have to fight the fight every day, you know, and, you know, we're dying. I don't, you know, we don't, you know, we have,
How can folks reach you to further these conversations, or to have access to that directory of physicians, or to get in touch with My Style Matters and My Breast Years Ahead, and to support or collaborate, or maybe they need an advocate or somebody to talk to? How can we reach you guys?
Absolutely. Thank you for asking that question. I actually have it on or the other way, whichever way it is.
back there, yeah.
But yeah, they can always email us, info@mystylematters.org. Visit our website. We're on social platforms at My Style Matters. Yeah, and we would love to be able to continue this conversation because it's needed. You know, the conversation is not going to stop until we stop dying.
There you go. And yes, same for me. I'm trying to figure out the side, diversehealthhub.org. And people can reach us at team@diversehealthhub.org. And I promise we will get back to you. So that's how you get in touch with us.
Love that. Ricky, how can we reach you and all of the different organizations that you're now bringing together in this alliance?
Yeah, we're trying Touch BBCA, you know, Ricky at touchbbca.org. It's RICK at touchbbca.org. All of our social media is Touch BBCA, and, you know, tweet me at Ricky Dove, and we'll hear, you know, just reach out, go to our Facebook page and send a message. And, you know, anyone who wants to be on the show and talk about stuff, if you got a solution, bring it to us. We're here. You know,
yeah, you got a topic, bring it to us. Absolutely.
Bring it to us. Yeah.
That's what it's for,
yeah. Next, we're going to talk about the COVID vaccine for breasties, and we have some good conversations coming up. So we posted that on our Facebook page. You can see what's coming. But
I'm getting mine Saturday. I'll keep you posted on it. Yeah, and I'm Dr. Monique Gary on all social media outlets. And if you need a referral to a physician in your area, if you have questions, if you need to know how to navigate the system a little bit better, you know, talk to Ricky, talk to Tia, talk to Tamara, talk to me, message us, let us know how we can support you through this breast cancer journey, because we know that you can feel really alone and isolated and not know who to turn to. And we got friends in almost every city across the country at this point. So if there's something that we can do, we will connect you with the resources and the people to do it. And we're happy to do that work. So let us know how we can support you. Anybody who's watching, please share this show with your loved ones, because we have got to move this conversation forward into something that's actionable, holding accountability, like Tia said, and making sure that people have the resources that they need. So we want to thank our
Let's check back
sponsors.
in 6 months. Let's check back in 6 months
Yep.
and say,
I
okay,
love that.
what? Let's check back in and say, okay, who'd you get to do what? Or how do we do this? And keep a tab on it. And if you send me stuff, I'll post it. Let's talk about what we did and how we're going to make things happen. And everybody needs to do it with your doctors, with your families. And it's a crazy world right now. It can only get better.
Breast health and health literacy. If I heard nothing else today, I heard that clarion call. So breast health and health literacy is something that we can all do. Anybody who's watching.
Yep. Check the breasts that you love. We know you have a pair.
Or somebody you love has some.
Right.
Health matters.
Yes. We hope this has been relatable, reliable, and real. That's what we set out to do every single Wednesday night at 6 p.m. Right, Ricky? Right here on blackdoctor.org. And we are so very thankful to them for the opportunity to come before you and talk about these important topics. So the doctor's in.
The doctor's in. Thank you guys so much. Rescue love. Rescue love.
Thanks.
Rescue love. Take care. Thank you.
Bye, ladies.
Bye.